Welcome back to the deep dive. I want to start today by setting a scene. It's a scene I think every single person listening has experienced, or at least watched in horror as it happened to someone else.
Oh, I think I know where this is going.
You're in a meeting, a really important meeting, or maybe a first date. The lighting is low, the mood is serious, and then you feel it. That unmistakable, terrifying tickle deep in the back of your nasal cavity.
The calm before the storm. It's the worst feeling.
It is the absolute worst. You try to suppress it, you wiggle your nose, you press your tongue to the roof of your mouth, all the little tricks, but it's no use. Your eyes start to water, you look like you're weeping over the quarterly earnings report.
Right, you're trying to play it cool, but your face is betraying you completely.
Completely. And then boom, the sneeze. But it's not just one sneeze, it's 3, it's 5, and suddenly you can't breathe through your nose at all. You are a mouth-breathing mess.
It is the universal humbler. The stuffy nose.
Yeah.
We tend to dismiss it as a minor annoyance, right?
Yeah.
The little sniffle. But today, we are going to completely dismantle that idea. Because when you actually look at the source material we have today, which I should mention is this dense, detailed clinical chapter on respiratory disorders, you realize that what is happening in that meeting room isn't just a tickle.
No.
It is the sophisticated, albeit completely misguided, biological war being waged inside your head.
That is the perfect way to frame it. A war. We are diving deep into allergic rhinitis today, and I love the way our sources approach this. We aren't just talking about which tissue brain is softest.
No, we're going way deeper than that.
We are talking about inflammation of the nasal mucous membranes. The goal for this deep dive is clear. We want to move past just suffering through allergy season. We want to understand the mechanisms, the actual gears and levers the body pulls, so that we can understand how to actually treat it effectively.
Knowledge really is the best antihistamine, or at least it helps you choose the right one, because allergic rhinitis is fundamentally a case of mistaken identity.
Yeah.
It is. It's a biological error.
A mistake.
A huge mistake. It happens when inhaled particles, things that are generally harmless like grass pollen, dust, cat dander, make contact with the membranes in your nose.
Yeah.
In a normal person, the body just ignores them.
Right. It just passes through.
Exactly. But in an allergic person, the body freaks out. It elicits a massive response mediated by a specific protein called immunoglobulin E, or IgE.
IgE. We are going to become very, very familiar with IgE today. It sounds like the ringleader of this whole operation.
It is the absolute culprit.
Right.
But before we get into the nitty-gritty biology of how IgE wreaks havoc, I think we need to pause and establish why this matters. I think there is a tendency to minimize allergies.
Yeah.
Oh, take a Benadryl and get over it.
Right. It's not a broken leg.
Yeah.
It's not, heart disease.
True, it's not. But the source text lays out the impact, and it is startling. It's not just about sneezing. We're talking about fatigue, malaise, insomnia.
The insomnia part really struck me because you don't think about it, but if you can't breathe, you can't sleep. It's that simple.
Exactly. And that leads to poor performance at work, poor grades in school. It drains you. I mean, imagine trying to function cognitively when your body is fighting a chronic inflammatory battle 24/7.
Your immune system is just constantly running in the background.
It's burning calories fighting a ghost. You aren't just sniffly, you are physically exhausted.
And there is a darker connection here, too, that I think we need to highlight right at the top. The source material mentions a very, very strong link to asthma.
This is crucial. Allergic rhinitis and asthma are often described as one airway, one disease. The upper airway, the nose, and the lower airway, the lungs, they're all connected.
It's one system.
It's one big tube. And the source highlights that between 10% and 40% of patients with allergic rhinitis also have asthma. That is a huge overlap.
40% is a massive number. That's almost half, potentially.
It is. Uncontrolled inflammation in the nose can actually signal, or even worsen, trouble in the lungs. So treating the nose isn't just about comfort. It's about protecting the entire respiratory system.
Okay, so let's unpack this biology. I want to know exactly what is happening at the cellular level when I inhale a piece of ragweed. How does the body turn a harmless bit of plant dust into enemy number one?
Right.
The text breaks this down into steps, starting with something called sensitization. This is the backstory, right? This happens before the sneeze?
Correct. This is the prequel, and this is really important. You don't have an allergic reaction the very first time you encounter a new allergen. You have to be sensitized first.
Okay, walk us through that. What does that even mean to be sensitized?
So imagine you are a genetically predisposed host.
Okay.
That means your DNA has handed you a loaded gun, basically.
Yeah.
You inhale an airborne allergen, let's say it's ragweed pollen. It enters your nose. It lands on the mucosa, that wet lining inside.
Right.
Now, in your body, there are cells called lymphocytes.
Lymphocytes.
Think of lymphocytes as the intelligence officers of the immune system. They're sitting in a back room looking at surveillance photos of everything that comes into your nose.
Okay, they're the analysts.
They're the analysts. And in a non-allergic person, the lymphocyte looks at the ragweed and says, hey, it's just a plant. Ignore it. Stand down.
But in our listener with the stuffy nose.
In the allergic person, the intelligence officer panics. They look at that ragweed and they misidentify it. They think it's a parasite. They think it's a deadly threat. So they slam the red button.
Whoops.
Big whoops. And they order the production of a specific weapon, antigen-specific IgE.
And this IgE doesn't just float around aimlessly, right? It has a job to do.
No, it has a very specific mission. It goes and binds to the surface of mast cells.
Mast cells. I love the name. It sounds sturdy. What is a mast cell?
I always picture mast cells as soldiers, standing guard at the border lining, your nose, your lungs, your skin. They're everywhere.
Yeah.
But they aren't just standing there with rifles.
Okay.
They're holding hand grenades.
Hand grenades.
Literally. They are packed full of granules containing explosive chemicals. When the IgE binds to the outside of the mast cell, it's like putting the pin in the grenade and then taking the lever down. The trap is set. The system is primed.
So at this point during sensitization, does the patient feel sick? Do they feel anything at all?
No. That's the trick. You feel totally fine. Your immune system is holding a loaded weapon pointed at ragweed, but you have no idea. You are walking around breathing easily, completely unaware that the next time you see ragweed, it's going to be war.
So that's step one. The trap is set. Now let's talk about step two, the attack. The source describes this as having two distinct phases, which I found fascinating because I think we usually just lump it all together as allergies. But there's an immediate reaction and a late phase reaction.
And distinguishing between these two is the key to understanding why you feel the way you feel and, why certain treatments work and others don't. Let's start with the immediate reaction. This is the early phase.
This is the sneeze, the one in the meeting.
This is the explosion. This occurs within seconds to minutes of re-exposure.
Wow, that fast.
Seconds. You breathe in that pollen again, it lands on the mast cell, it hits those IgE antibodies that are just waiting for it, and boom, cross-linking happens.
Cross-linking, what does that mean?
The allergen particle is just the right size to connect two IgE antibodies together like a bridge. It completes the circuit.
It's the trigger.
It's the trigger. The mast cell degranulates. It dumps its payload.
And what's in the payload? What are those grenades made of?
A chemical soup. The most famous one, of course, is histamine. But it's not alone. You have leukotrienes, prostaglandins, tryptase, chitins. It's this whole cocktail designed to destroy a parasite.
But there is no parasite. There's just a piece of dust.
Exactly. But the tissue doesn't know that. These chemicals wreak absolute havoc. Let's look at what they do. First, vasodilation.
That sounds like plumbing.
It is. It means the blood vessels widen. When the vessels in your nose widen, the tissue engorges with blood. That's why you feel stuffed up almost instantly.
Oh, so it's not mucus at first, it's swelling.
It's swelling. The air passage physically shrinks because the walls are swelling inward.
Okay. And then the next one here is vascular permeability.
That means the vessels become leaky. Fluid escapes from the blood vessels into the surrounding tissue. This causes edema, more swelling, and it provides the fluid for that sudden watery, runny nose.
Rhinorrhea. The faucet turns on.
Faucet turns on, exactly. And histamine specifically stimulates the nerve endings, which causes that maddening itch and the sneeze reflex.
Mm-hmm.
The sneeze is the body trying to physically blast the invader out at like 100 miles per hour.
So all of that, the sneeze, the itch, the initial running, that's the immediate phase. That's the mast cell grenade going off.
Correct. But here is where it gets really interesting, and this is the part people miss. The late phase reaction.
Yeah, this is the sneaky part. The source says this happens 4 to 8 hours later.
Yes. So imagine you go to a picnic at noon. You sneeze a bit, you take an antihistamine, you feel okay. You drive home. But then around 8:00 p.m., you start to feel terrible.
But not sneezing terrible. It's a different kind of terrible.
Exactly. The sneezing might have stopped. But now you are congested, deeply, profoundly congested. Your nose feels like it has been filled with concrete. This is the late phase.
What is causing this if the mast cells already exploded hours ago?
The mast cells called for backup. During that initial explosion, they released signals, they're called cytokines, that summoned other immune cells. Eosinophils, basophils, neutrophils, thymus-derived helper lymphocytes. The heavy infantry has arrived.
The second wave.
It's the second wave. And what do?
What do they do?
They set up shop in your nasal tissue and create persistent chronic inflammation. They damage the epithelial cells. They keep the tissue swollen and boggy. This phase isn't about the quick sneeze. It's about chronic obstruction.
That explains the blocked feeling that just won't go away for days.
It does. And it explains why simple antihistamines sometimes feel like they stop working. Antihistamines are great for the initial explosion, the histamine part. But they aren't as good at stopping this late phase inflammatory riot.
We're going to get to the drugs later, but that is a huge light bulb moment for me. If you are treating the 8:00 p.m. congestion with a drug meant for the noon sneeze, you're using the wrong tool.
Precisely. You have to match the mechanism of the drug to the mechanism of the symptom.
Okay. Before we get to the medicine cabinet, though, let's play detective. The source breaks down how doctors actually diagnose this, and it separates the enemy into two main camps: seasonal and persistent.
This is a classic classification, and it's really useful. Seasonal is what we traditionally call hay fever.
Which, ironically, usually has nothing to do with hay and doesn't cause a fever. I've always found that funny.
True on both counts. Seasonal rhinitis is predictable. It's tied to the calendar. If you are miserable in April, it's almost certainly tree pollen. If you're miserable in June, it's grasses. If you're miserable in September, it's weeds like ragweed.
And the symptoms for seasonal tend to be louder, more dramatic.
Yes, more acute. Violent sneezing fits, intense itching of the eyes and nose, profuse watery discharge, the very active misery.
Okay, compare that to the second camp, persistent.
This used to be called perennial, meaning year-round. These are the patients reacting to indoor allergens. Dust mites, animal dander, molds, cockroaches even.
Stuff that is always with us, no matter the season.
Exactly. And because the exposure is constant, the symptoms change. You don't get those violent sneezing fits as much. Instead, you get this chronic, low-level misery, a constantly blocked nose, a constant post-nasal drip. You might lose your sense of smell. You just feel clogged.
And the text notes a cruel twist of fate. Many people have both.
Ah, the dual sufferer. It's so common. You have a baseline of misery from the dust mites in your house, so your nose is already inflamed. And then spring comes along, tree pollen hits, and you go from bad to completely incapacitating.
I want to talk about the visual evidence of this, the clinical presentation. The source describes something called the allergic face. This was fascinating to me because once you read this description, you start seeing it everywhere. It's like learning a new word and then hearing it all day.
It is very distinct, especially in children, because their facial structures are still developing. But you see it in adults too, for sure.
Let's start with the eyes. Allergic shiners.
These are dark, almost purple-gray circles under the eyes.
Now, I always assumed that was just because allergy people don't sleep well. They're tired.
Sleep is part of it, for sure, but there is a physical mechanism. It's caused by venous congestion.
Venous congestion.
Yeah. The blood vessels inside the nose are so swollen that they press against the veins that drain blood from the face. The blood can't drain properly, so it pools in the loose tissue under the eyes. It's essentially a bruise caused by traffic congestion in your veins.
That is wild. It's a hydraulic issue. It's a plumbing backup.
It's a plumbing backup, basically. And then there's the transverse nasal crease.
This one I had to look up pictures of. It's a literal line across the nose.
Yes, a horizontal line across the lower third of the nose, right above the tip.
Yeah.
It is a dead giveaway. It is caused by the allergic salute.
The allergic salute. It sounds like a secret society greeting.
It sort of is. It's the gesture people make when their nose itches and runs. They take the palm of their hand and rub the nose upward.
Right. You push the tip of the nose up. I'm doing it right now.
Everyone does it. It relieves the itch and temporarily opens the airway. If you do that repeatedly, hundreds of times a season, year after year, you physically break the collagen in the skin and create a permanent crease.
Wow. So if you see that line on someone, you know that person has been battling rhinitis for a long, long time.
It's a badge of the battle, yes. A little scar from the war.
And the third feature, adenoidal breathing.
Which is a polite way of saying mouth breathing. It's because the nose is completely obstructed, so the patient just keeps their mouth open to breathe.
And this is really serious in kids, right?
It's very serious in children. If a child breathes through their mouth exclusively for years, it creates a high-arched palate. It changes the way the teeth come in, causing malocclusion. It actually elongates the face.
That is incredible. A little allergy problem can reshape your actual skull.
It highlights why we shouldn't just ignore sniffles in kids. It has long-term developmental consequences.
Okay, so we suspect allergies. The doctor sees the shiner, sees the crease. How do they confirm it? I know about the skin prick test. Everyone knows that one. But are there other ways?
There are. You can get really basic and look at the snot itself.
Gross. But informative, I guess.
It is, but it's useful. A nasal smear. They scrape the inside of the nose and put it under a microscope. And they are looking for eosinophils. Remember, those are the white blood cells that come in during the late phase.
The heavy infantry, the second wave.
Right. If you have a viral cold, you'll see neutrophils. If you have allergies, you see eosinophils. It helps distinguish between I caught a cold and I'm allergic to my cat.
But the gold standard is still the skin test.
Yes.
The one on the arm.
Percutaneous testing. They drop a tiny bit of liquid allergen on your arm or back and scratch the skin. Then they wait 15 minutes. If you are allergic, the IgE on your skin's mast cells will react, release histamine, and you get a wheal and flare, a little hive.
It sounds barbaric, but it works.
Yeah.
It's very direct.
It's immediate and visual, but there's a catch. You have to stop taking antihistamines for almost a week before the test.
Which for some people is impossible. They would be absolutely miserable.
Exactly. Or maybe the patient has severe eczema and you can't find a patch of clear skin to test. In those cases, we use the blood test, the RAST, or radiolargosorbent test.
How does that one work?
They take a sample of your blood and mix it with allergens in the lab to see if your blood contains specific IgE antibodies against them. It's safer. There's no risk of anaphylaxis. But the text notes it is generally less sensitive than the skin test.
So it might miss a mild allergy.
It might, yeah.
Okay, so we've diagnosed it. We know the enemy. Now we need a battle plan. Segment 3 of our outline is the fortress, non-pharmacologic therapy. The strategy here is simple: avoidance.
The most effective treatment is to simply not be near the thing that makes you sick.
Simple to say.
Difficult to accomplish, as the source dryly notes. I mean, you can't avoid air, but you can manage your environment.
Let's break down the big triggers. Mold. This is a tough one because it hides.
Mold is insidious. It loves moisture. So the #1 weapon against mold isn't a chemical spray, it's a dehumidifier. The target is to keep household humidity below 50%.
Why 50%? What's the magic number there?
Below 50%, most molds go dormant or die. They just can't grow. Above 50%, they thrive. So if you have a damp basement, you are running a mold factory, you have to dry it out.
And if you see it.
You have to kill it. Bleach or disinfectant on the shower curtain, on the windowsill, wherever it pops up.
Now let's talk about a heartbreaking one, pet dander.
This is the conversation every allergist hates having.
The source was pretty blunt about this. No beating around the bush.
It was ruthless, it says. Patients sensitive to animals benefit most by removing the pets from the home. Period.
I can hear the listeners groaning. You can take my Sudafed, but you can't take Fido.
I know. It's a prescription that is almost never filled. People choose the dog over their nose every single time. But we have to be honest about the science. If the dog is in the house, the dander's in the house.
What if we just keep the dog out of the bedroom? That's the compromise, right?
It helps a little, but not as much as you'd think. Dander is incredibly lightweight. It floats. It travels on your clothes. It gets into the HVAC system. It's sticky.
It's everywhere.
It's everywhere. Even if you remove a cat from a home today, high levels of allergen can persist for months.
Months?
Yeah.
Even after the cat is gone?
Yes, it's embedded in the carpets and upholstery. So if you aren't going to get rid of the pet, and let's assume you aren't, you need to be aggressive with HEPA filters, vacuuming, and washing the animal weekly. But the text warns, these measures are significantly less effective than removal.
Tough love. Okay, let's move to dust mites. This is where I want to do some myth busting. I feel like the standard advice for years has been, go buy the expensive allergy-proof mattress cover. I have spent hundreds of dollars on these things. They are crinkly, they are hot, and they are expensive.
You might want to brace yourself for this.
Oh no, don't tell me I wasted my money.
The source material cites studies regarding these impermeable bedding encasements. And the verdict is, well, it's underwhelming.
Don't tell me they don't work.
The text states that as a standalone therapy for adults, encasing bedding and washing linens in hot water has little benefit.
Little benefit? How is that possible? It's a plastic bag around the mattress. The mites can't get out.
It keeps the mites in the mattress away from you, yes. That part is true. But here's the problem. Dust mites aren't just in your bed. They are in the carpet. They are in the curtains. They are in the upholstered chair in the corner. They're in the clothes in your closet.
So I'm protecting myself for 8 hours in bed, but getting exposed for the other 16 hours, I'm in the house.
Exactly. And even the bedroom, unless you rip out the carpets and take down the curtains, the fortress of the bed is surrounded by the enemy. The source suggests that these covers might help in children, but for adults, the data is conflicting and often disappointing.
That is a massive aha moment. We put so much faith in these products.
You want a silver bullet. I bought the sheet. I'm cured.
Mm.
Biology is rarely that simple.
And finally, pollen. You can't control the outdoors.
No, but you can control your exposure to it. The strategy here is hide. Keep the windows closed. I know fresh spring air is nice, but if you have hay fever, that breeze is poison.
What about gardening or mowing the lawn?
Wear a mask. An N95 mask isn't just for viruses. It stops pollen beautifully. Create a physical barrier between the flower and your nose.
Okay, we've tried to build the fortress, but the walls have been breached, the pollen is inside, the cat is on the lap. We need weapons. Let's talk pharmacotherapy. Chemical warfare.
We have a vast arsenal, but you have to know how to use it.
Let's start with the infantry. Antihistamines.
A staple. Every medicine cabinet has them. To understand them, we have to go back to that parking lot analogy for receptors.
Okay, paint the picture for us.
Imagine your cells have little parking spots on them called H1 receptors. When histamine is released by the mast cell, it drives around looking for a spot. When it pulls into an H1 parking spot, it pushes a button that says sneeze or itch.
Simple enough.
An antihistamine is a drug that looks like a car, but it doesn't push the button. It pulls into the parking spot and just sits there. It blocks the spot.
It's an imposter.
It's an imposter. So when the real histamine arrives, it has nowhere to park. It circles around and eventually gets broken down.
So it's a competitive blocker.
Exactly. It's an H1 receptor antagonist. But here is the critical detail that explains why people say this stuff doesn't work.
Timing. It's got to be timing.
It's all about timing. Think about the parking lot. If the lot is already full of histamine cars because you've been sneezing for an hour, taking the pill now won't help immediately. The drug can't park if the spot is already taken.
It can't tow the cars away. It can't kick the histamine out.
Not really. It has to wait for the histamine to leave naturally. That is why the text emphasizes, take the antihistamine 1 to 2 hours before exposure. You need to fill the parking lot with dummy cars, the drug, before the real cars, the histamines, show up.
That changes everything. If I know I'm going to my friend's house who has a cat at 6 p.m., I need to take the pill at 4 p.m.
Precisely. If you wait until you are sneezing, you are playing catch-up and you're going to lose.
Now, let's talk about the different types. We have generations. First gen versus second gen. What's the deal there?
The first-generation agents are the old-school ones. Diphenhydramine, which is Benadryl, chlorpheniramine. These are potent, they work, but they are dirty drugs.
Dirty, how so?
They are non-selective, and crucially, they are lipid-soluble. They dissolve in fat. That allows them to cross the blood-brain barrier effortlessly.
They get into the brain.
They flood the brain. And in the brain, blocking histamine causes profound sedation. It slows down your processing speed. It makes you drowsy.
That's why Benadryl knocks you out.
Exactly. The text warns that it can interfere with driving ability. It's actually comparable to alcohol intoxication in terms of reaction time. But people pop them and drive to work all the time.
Is there ever a time you want that effect?
Yes, absolutely. Remember the insomnia. If your allergies are keeping you awake all night, itching and sneezing, a first-generation antihistamine is a 2-for-1 deal. It stops the itch and it puts you to sleep. A bug becomes a feature.
But for the daytime, for that big meeting, we want the second generation.
Right. Loratadine, which is Claritin, fexofenadine, which is Allegra, cetirizine, which is Zyrtec. These were engineered to be lipophobic. They hate fat. So they struggle to cross the blood-brain barrier.
They can't get into the brain as easily.
Very little gets in. So they stay in the body, blocking the nose receptors, but they leave the brain alone.
Should you get the blockade without the zombie mode?
Exactly. Much better for functioning during the day.
What about side effects? Is it just drowsiness with the first-gen stuff?
No, the text mentions anticholinergic effects. This is the drying out phenomena.
Dry mouth.
Dry mouth, dry eyes, but also potentially urinary retention and constipation. Because they block a neurotransmitter called acetylcholine, they slow down the rest and digest functions of the body.
So if you have an enlarged prostate or something?
You have to be very careful. Men with benign prostatic hyperplasia can find themselves completely unable to urinate if they take a strong first-gen antihistamine. It tightens the sphincter. Also, patients with glaucoma need to be careful because it can increase pressure in the eye.
It's not just a harmless candy. You have to think about these things.
No drug is. Ever.
We also have antihistamines that go directly into the nose. The text mentions azelastine.
Azelastine is a nasal spray. The benefit is speed. You're putting the drug right on the crime scene, so to speak. But the text notes a downside.
Uh,
Systemic absorption.
it still gets into the blood.
About 40% of it does, yeah. So even though it's a spray, it can still cause drowsiness in some people. And a lot of patients hate the taste. It drips down the back of the throat, and it's very, very bitter.
And for the eyes, the itchy, watery eyes.
If the oral pills aren't helping the itchy eyes, go for the drops. Olopatadine, levocavastine, they work directly on the conjunctiva. Sometimes you need a topical solution for a topical problem.
All right, that's antihistamines. They block the signal. Now let's talk about chemical warfare part 2. Decongestants. These work completely differently.
Completely.
Mhm.
If antihistamines are diplomats trying to block a message, decongestants are engineers. They work on the plumbing.
How so?
They're sympathomimetics. That's a mouthful, but it means they mimic the sympathetic nervous system, your fight or flight system. When you are running from a bear, your body clamps down blood vessels in non-essential areas to send blood to your muscles.
So these drugs trick the nose into thinking we are running from a bear.
Basically, they cause vasoconstriction. They squeeze the blood vessels in the nasal lining.
And when the vessels shrink?
The swelling goes down, the airway opens up. It is purely mechanical. It physically makes the tissue smaller.
That sounds great. That sounds like a miracle. Why don't we just use these all the time?
Because of the danger zone.
Yeah.
And we have to talk about topical decongestants. The sprays like oxymetazoline, which is Afrin.
I've heard horror stories about that stuff.
The text is adamant about this. The rule is, do not use for more than 3 to 5 days. Full stop.
Why? What happens on day 6? What's the big deal?
Rhinitis medicamentosa, the rebound effect.
Okay, explain that. What is rebounding?
If you keep artificially squeezing those blood vessels shut, the tissue starts to starve for oxygen and nutrients. The body fights back. It creates more receptors to try and force the vessels open. It releases its own chemicals to vasodilate.
So when the drug wears off?
The dam breaks. The congestion comes back, but now it is twice as bad as the original allergy. The patient panics, can't breathe, so they spray again.
And the cycle tightens. It gets worse and worse.
It becomes a physiological addiction. You aren't treating allergies anymore, you're treating the withdrawal from the spray. We see patients who have been addicted to nasal spray for years. Their nasal tissue is wrecked.
How do you get off it? It sounds awful.
It is miserable. You have to stop cold turkey. You are going to be completely blocked for a week or two while the receptors reset. Sometimes we give steroids to help bridge the gap, but the best cure is prevention. Respect the 3-day limit.
What about the pills? Pseudoephedrine, the stuff behind the counter. Sudafed.
Pseudoephedrine is the systemic version. You swallow it, it has a slower onset, but it doesn't cause that gnarly rebound effect.
But you have to show your driver's license to buy it now.
Right, the meth connection.
Yeah.
Pseudoephedrine is the raw material for making methamphetamine, so governments restrict it. But strictly speaking, as a decongestant, it is very effective.
But because it stimulates that fight or flight system.
It raises blood pressure, it raises heart rate. If you have hypertension or a heart condition, this is a dangerous drug for you.
Yeah.
It can push your pressure into the danger zone.
And then there is phenylephrine, the stuff on the shelf that you don't need an ID for.
Right. It replaced pseudoephedrine in many OTC products. It's safer. You can't make meth with it. But there is a massive debate in the clinical community about whether it actually works at the oral dose. Many argue it's barely better than a placebo.
So if you want the real stuff, the stuff that works, you have to go to the pharmacy counter.
Yes. Just be ready to end up on a list somewhere.
Okay, so we've done blockers, we've done squeezers. Now we bring in what the outline calls the heavy artillery. Corticosteroids. The source calls these the gold standard.
And they are. For persistent rhinitis, they absolutely are.
Yeah.
Fluticasone, Flonase, mometasone. These are arguably the most effective single therapy
Why are they so much better than antihistamines?
because they are broader. Antihistamines block one chemical histamine. Steroids go to the nucleus of the cell and turn off the gene expression for inflammation. They block mediator release, they suppress the neutrophils, they inhibit that nasty late-phase reaction we talked about. They calm the entire riot down at its source.
If they are so good, why doesn't everyone start with them? Why even bother with antihistamines?
2 reasons. 1, the word steroid scares people. They think they're going to grow muscles or get roid rage.
Right, they think of bodybuilders.
Exactly. We have to clarify. These are corticosteroids, not anabolic steroids. They reduce inflammation, they don't build muscle.
Yeah.
And because they are topical sprays, very little gets into the rest of the body. They're very, very safe.
And what's the second reason?
Patience. We live in an instant gratification society. If I take a decongestant, I breathe better in 10 minutes. If I take a steroid spray, I feel nothing.
It takes time to work.
It takes time to change the cellular machinery. The peak response can take 2 to 3 weeks of daily use.
3 weeks. That's a long time to wait when you feel miserable.
It is. So the patient tries it for 3 days, says this is garbage, throws it away, and goes back to the addictive decongestant spray. That is the most common failure mode. You have to view nasal steroids like gardening. You are tending the soil. You have to do it every day, and eventually the weeds stop growing.
And technique matters, right? You can't just spray it into a clogged nose and expect it to work.
Correct. The text suggests clearing the nasal passages with saline first. If your nose is full of mucus, the spray just hits the snot and drips out. You need to wash the wall before you paint it.
That makes perfect sense. Let's quickly hit the other agents mentioned in the source. Cromolyn sodium.
Cromolyn is fascinating because it's a mast cell stabilizer.
What does that mean, stabilize?
Remember, the mast cell is the soldier with the grenade. Cromolyn is like putting a safety lock on the grenade. It coats the cell membrane and prevents it from popping open, even if the IgE is triggered.
That sounds amazing. That sounds like the perfect preventative. Why isn't it the most popular drug?
Because it is high maintenance, you have to use it 3 or 4 times a day, every single day. And this is crucial. You have to start using it before allergy season starts.
It's a shield, not a sword.
Exactly. If the grenades are already exploding, Cromolyn is useless. It can't put the pin back in. You have to stabilize the cell before the war starts.
Okay, and what about epitropium bromide?
That's a niche player. It's an anticholinergic spray. It does one thing, but it does it very well. It dries up water. If your main symptom is just a dripping nose like a faucet, but you aren't sneezing or congested, this is your drug. It turns off the glands that produce the watery fluid.
So for the person who always needs a tissue for the drip.
Precisely for them.
And finally, montelukast. That's Singulair, right?
Yes, Singulair. This is a pill. It's a leukotriene receptor antagonist.
Leukotrienes were in that chemical soup from the mast cells, right?
Yes, they are potent inflammatory signals that contribute to both allergies and asthma. Montelukast blocks them. It's convenient because it's a pill, but the text places it as third-line therapy.
So not the first choice.
No, it's generally less effective than the steroid sprays for most people. It's good for people who have both asthma and allergies, or for people who just absolutely refuse to put a spray up their nose.
All right, we've covered the drugs, we've managed the symptoms, but is there a cure? Can we fix the underlying problem? Let's talk about the long game. Immunotherapy. Allergy shots.
This is the only treatment that actually changes the biology. Everything else we've discussed is just putting a bucket under the leak. Immunotherapy fixes the roof.
It's often called the hair of the dog, which is a weird phrase for it.
It is. The principle is paradoxical. You inject the patient with the very thing that makes them sick.
I'm allergic to cats, so shoot me up with cat juice. That seems crazy.
Basically. But you start with a tiny, incredibly dilute dose, microscopic, and you slowly, over months, increase the concentration.
What is the goal? What are you trying to do to the immune system?
You're trying to induce tolerance. You are trying to retrain the immune system. We want to shift the production of antibodies. Remember, IgE is the bad guy.
The one that triggers the grenade.
Right. We want the body to stop making so much IgE and start producing IgG instead, specifically blocking IgG.
How does IgG help? What does it do?
Think of IgG as a linebacker. It floats in the blood and tissue. When the allergen enters, the IgG intercepts it. It tackles the allergen before it can reach the mast cell.
So the IgE on the mast cell never gets triggered because the IgG intercepted the message. It never saw the pollen.
Exactly. It blocks the pass. And over time, it also changes the T-cell balance in the body to a less allergic, more tolerant profile.
But this isn't a weekend project. This sounds like a huge commitment.
Oh, it's not. This is a marriage. It takes 3 to 5 years. You go in for shots weekly at first, then monthly. It is a massive time commitment.
So who should do this? Who is the ideal candidate?
The candidate is someone with severe symptoms who has failed pharmacotherapy. The drugs don't work for them, or the side effects are intolerable. Or someone who just hates taking meds every single day and wants a permanent fix.
And are there risks? It sounds a little risky.
The biggest risk is anaphylaxis. You are, after all, injecting the enemy. There is a small chance the body reacts violently. That's why you have to do it in a doctor's office, and you have to wait there for 30 minutes after the shot. They need to have epinephrine ready just in case. It's rare, but it's serious.
So we've surveyed the entire battlefield. We've got the fortress of avoidance, the infantry of antihistamines, the special ops of decongestants, the heavy artillery of steroids, and the diplomatic solution of immunotherapy. How do we put this all together for the listener who is just miserable right now?
The text outlines a treatment algorithm. It's a logic tree, a step-by-step guide.
Walk us through it. What's step 1?
Step 1, Environment. Do the easy stuff first. Fix the humidity in your house. Kick the cat out of the bedroom if you can.
If you can. A big if.
A very big if. Close the windows during pollen season. Start there.
Step 2.
Assess your specific symptoms. Don't just go to the store and buy a box that says allergy medicine. Think about what's bothering you most. If you sneeze and itch, that's histamine, try an antihistamine.
And if you're just totally blocked up?
If you are blocked, a decongestant for short-term relief, but a nasal steroid for long-term control.
And if you have everything, the sneezing, the itching, the congestion, the whole miserable package?
The nasal steroid is the champion. It covers the broadest base of symptoms. It's the best place to start for most people with persistent problems.
And the most important part, what's the final piece of advice?
Evaluation and adherence. Give it time. Don't quit the steroid after 3 days. Use the technique correctly. Saline first. And if you are still miserable after a month of honest effort, that's when you go talk to the specialist about allergy shots.
It really is about matching the tool to the job. You know, we started this by talking about how annoying a stuffy nose is, but after diving into all this detail, I have a newfound respect for the biological energy involved here.
That is a great final thought. Think about the energy expenditure. Your immune system is working incredibly hard. It is synthesizing complex proteins, mobilizing armies of cells, creating fluids, swelling tissues, all to protect you from a microscopic grain of grass pollen that poses zero actual threat to your survival.
It's powerful, but it's just confusing.
It's a biological Ferrari being used to tow a tricycle. It's complete overkill. It's a reminder of how potent our defenses are, but also how delicate the calibration needs to be. When that calibration is off by just a hair, you get rhinitis.
Well, I certainly feel better equipped to handle the next allergy season. I'm going to go check the humidity in my basement right now, actually.
Good plan. It's a good place to start.
Thanks for listening to The Deep Dive. Until next time, breathe easy.